Good morning, everybody. Good morning to 600 of my closest nurse practitioner friends. So I'm so thankful and glad that you took the time today on a Saturday. We do understand your time is precious. We want to make this a very valuable few hours, and we want you to really get some great information to move forward with. But again, thank you so much for joining us. On behalf of Integrity Continuing Education and Global Education Group, we are honored that you took the time to be with us for the 2023 Nurse Practitioner Summit. My name is Brett Snodgrass. I'm a family nurse practitioner. It says here, award-winning blogger. I am the NP mom. But currently, I'm palliative medicine operations director for a large hospital system in Memphis, Tennessee. That is where I'm currently practicing. I'm a director, but also a clinician, and always a clinician at heart. So always at the bedside, taking care of patients. And so that's kind of my day-to-day work. And then I'm honored to get to be with you today and really walk through where we've come from and talk a little bit about resiliency, and then I want to get out of the way and get you some really great information and really great topics today from some different speakers. So again, thank you. Provider statement, there is CME available for the next few hours, CMA activity for ACCME credit provided by Integrity Continuing Education. As always, we have program supporters who we also are grateful that allow us and allow this to be a free event. So those are on the screen: Actelion Pharmaceuticals, a Janssen company of Johnson & Johnson, GRAIL, and Merck Sharp Dohme. So thank you so much to our program supporters. Our educational partners, thank you, thank you, thank you. To our nurse practitioner associations across the nation. We are thrilled to partner with Florida Nurse Practitioner Network, Maryland Academy of Advanced Practice Clinicians, the Nurse Practitioner Association of New York State, and Pennsylvania Coalition of Nurse Practitioners. So thank you so much. I have some great friends associated with these associations, so I thank you so much. I hope you're tuning in. And again, we could not do these continuing education offerings without you. How do you obtain your CE? That's vitally important. So many of you are viewing on live webcast, and that's probably the easiest way to view it, but we also have a social media platform as well. But if you're on the live webcast, you're getting pre-test questions already pushed out to you. You will get them before each of the presenters begin, and we ask that you answer those. There will also be post-test questions. So you're going to view the program content, answer the real-time polling questions, and then finally complete the evaluation, which will be sent to you. I apologize, the link to the evaluation is already available at the top of your screen and will also be provided at the end of the program. We're not new at the CE thing, so we know we must provide all of these things and do all of these things. And then your certificate will be processed and emailed within 4 weeks. Now, if you're on the social media platform, you too will and can get CE, CME credit. You can have the option of joining us. They will send you a link to join us in that live webcast, where you may remain on social media. You too will view the program content. You'll complete the pre-test, post-test, and evaluations forms, and you'll be sent a link for those. And this is available now on Facebook, Twitter, and LinkedIn. I would tell you, if you're viewing, feel free to share this, your other providers out there. And you too are going to get you'll get the continuing education in about 4 weeks emailed to you. All right, so we're going to have some polling questions, and these are going to be real time. I want you to just click on the button that correlates to your preferred response. Unfortunately, this feature isn't available to you if you are viewing on our social media platforms, but you will get a link sent for those pre-test and post-test questions. And here's the link, social media viewers. If you'd love to come on and be on our live webinar, this is the link to go to, and you can do that now. All right, let's start with our first audience polling question. These are always fun. I always like to know where everyone is. So, which of the following most closely describes your practice setting? Is it a hospital network, institutional settings such as skilled nursing facility, corrections, mental health, psychiatric units? Are you in retail pharmacy, urgent care, private practice, group practice, or other? And if other, please type that in the chat box now. A lot of people in hospital networks, you're right there with me. Urgent care, institutional settings. So these are our top four most common. Let me scroll down. I say that. Oh, I don't know what I just did. I apologize. Gotcha. Okay. So sorry. All right, let's move on. So exciting. So again, hospital networks. And people are working in a lot of different areas, aren't they? We'll talk about that in a little bit. What is your professional specialty? Primary care, family practice, acute care, adult geriatric long-term care, cardiology, oncology, hematology, pulmonology, respiratory, or other. I would clearly need to click other for these, but professional specialty that you currently work in. Primary care, family practice, acute care. Thank you to all for answering. This is so helpful to us, and there will be more of these polling questions coming. So without further ado, let's get into my keynote presentation. I'm not sure why it's dark here. My bottom slides look okay, but the top.
Oh, I'm sorry, you need to refresh your page real quick.
Uh-oh, I'm so sorry.
That's okay.
How about now? Everybody good?
Yeah, can you see it?
Yes, I can.
Okay.
So that was a glitch on my part. I am so sorry. As we know, there's always those hiccups early on. Let's get started. I am thrilled to be with you today. And just to tell you a little bit about myself, I am Dr. Brett Snodgrass. I get to say doctor, and I've been able to say doctor for, the last 2 months. So I recently finished my doctorate of nursing practice. I'm very proud of that. But am working in palliative medicine, as I told you previously. I've been a registered nurse for 26 years. I've been a nurse practitioner for 16. I am honored to do what I do every single day. And more than anything, I love to provide education to other nurse practitioners, but really just come up and partner along with you. This is a hard job. And I think if anything taught us that, COVID taught us that. I hate to talk about it, and I know everybody kind of rolls their eyes when we bring it up, but it really taught us what we were doing. It's hard things. We're doing the hard things, but we're doing it well. And we need you at the table, and we need you at the bedside, and we need you to do what you are doing. So I really want to spend the time and talk a little bit about resiliency. And I will share with you, I've oftentimes rolled my eyes at the term and burnout. I just always put my head down and worked really hard. But you know what? It's a real thing. And over the last few years, I have thought and really worked on my own resiliency and really combated my own burnout, and because I love what I do. So I'm excited to spend probably about the next 45 minutes talking about that, and really talking about some ways that we can combat that, and kind of how we got there, where we're going, how do we get there. So nonetheless, I do have one disclosure for you. I am on a speakers bureau with Salix Pharmaceutical. We'll not be talking about any of their products. Learning objectives, always important. Let's look at the evolution of nurse practitioners. I always love history, so let's look at it. Define both individual and workplace factors that really are influencing our well-being in this day and age. Explore the importance of boundaries in the midst of a crisis and characterize ways that wellness can truly foster within your teams, but most importantly, within yourself. And polling questions also have been pushed for this, so make certain you're answering your polling questions to be available to get your CE at the end of our presentations. All right, let's look first at the current landscape. I would love to tell you in our advanced United States of America that we are doing better than really what we're doing. But in fact, still in 2023, we have 101 million patients without adequate primary care access, and oftentimes just access to quality health care. Why is that? Well, what we've seen over the last easily 5 years, probably 10 years, we've seen more rural healthcare hospitals and rural access hospitals closing. We've also seen an exodus of providers leaving rural healthcare, leaving healthcare altogether. We see here down at the bottom, by 2026, we're expecting a shortage of up to 3.2 million healthcare workers. My daughter just graduated nursing school in May and just got out of orientation. So she's kind of living this new world and finally making a paycheck, which she's excited about. But what do? They're constantly calling and asking, can you work extra? Can you work overtime? We'll pay you double time. We'll just about pay you anything because they need healthcare workers. Most importantly, they need healthcare workers at the bedside. So again, why is there this access issue? It really has to do with the rural health hospitals closing down and a lot of providers truly leaving areas of great need. We also know we have 165 million patients without adequate mental health services. Many of the insurances do not include mental health services in their benefits, but also we know that we have so many in need of mental health services. The latest data says 1 in 5 people have some type of mental health need. We don't call it a disorder. They have a mental health need. So we need more practitioners on the front lines doing this hard work. Not only that, as we talk about all the patients without access and limited access to all of these services, we now have an aging population. We do a bang up job in the hospitals of keeping patients alive. We do. We can do that. And of course, I work in palliative medicine. Keep in mind, I'm not always talking about end-of-life issues, but what we see is we are able to keep patients alive longer. That's positive. And what we know is by the year 2040, 1 in 5 Americans will be 65 years of age and older. Are they more healthy? Maybe not, but we're able to extend life. So how do we take care of an aging population as we have more and more of those? Again, I don't want to paint a negative picture, but it's currently where we are in healthcare. Also, I'll just jump ahead and add here, this is where nurse practitioners come into play, and we have such a dire need to be at the table and to be at the bedside with our patients. You are doing great work. Here's what we know. Nurse practitioners and physician assistants or associates, as they're not now wanting to be called, and as they're changing their name, we're the most in-demand health professionals. And what do you hear your patients say when they talk about seeing a nurse practitioner? They listen to me and they explained things where I could understand them. And we know this because the US News and World Reports ranked nurse practitioners #1 in best healthcare jobs So NPs are increasing that access to care, but we know there are limitations, which we're going to talk about. Not only that, advanced practice providers now have an all-time high satisfaction and confidence rating. You are doing good work. I'm going to cheerlead you all the way through this next 45 minutes because you're doing great work. Don't let anyone tell you otherwise. I'll share with you, I've been in private practice for a number of years. Now I'm back in hospital practice. I have great colleagues, physicians, nurse practitioners, and PAs. I have great colleagues. We still know what the hierarchy looks like at the hospital, and we are still in 2023 competing and working to have that place at the table, fighting for the place at the table. But nonetheless, we are slowly chipping away at those tables to really get where we need, most importantly, to get our patients the care that they need and that they deserve. Every year, this looks better and better and better. And I was thrilled when we hit the tipping point of more states having full practice authority than not. And here we are. 27 states and Washington, D.C. currently have full practice authority. We know what that means. That means you do not have to have another profession oversee your work and the job that you're doing. We know that outcomes are there. We know we've been trained. We want to work to the highest level of our education. And we know that we are equipped and can do that. You did that when you passed that board certification. You can do those things. Now, it doesn't mean we're going to practice in a silo. And I always veer away from independent practice because none of us, I don't care what your profession is or what your letters are at the end of your name, nobody's practicing independently or in a silo. No, in fact, we all practice as colleagues and we refer back and forth to each other. But it's just the point that we need to continue this work and we need to move more and more states toward full practice authority. So a lot of our states here that are on this webinar are in those red and yellow states. My friends, we have work to do. I'm in a red state. Most commonly in the states you're looking at that are red and that are yellow. In fact, what we find is the states that are green have far better outcomes and the data is there. They're getting great care. And who are they getting their great care from? Our nurse practitioners. So thank you for what you're doing. Just to remind you, we know that nurse practitioners have a graduate and many cases now have doctorate level educations. We evaluate, diagnose patients, order, interpret diagnostic tests, initiate management treatment, of course, prescribing medications. And I'll add here, and we are specializing. You are finding, and I'm excited about our speakers today, these are specialty prepared nurse practitioners in different needs of health and in different areas of specialty, and we are so glad you are there and doing that. So what's the future of nursing? Here's where we are. We know that the Robert Woods Jones education and all of that, we've had white papers come out, national academies, National Institute of Health. Everybody has really worked and said over the years, there's been different futures of nursing and what it's going to look like. Well, the future of nursing, and the most recent one out, is really talking about the power of the nurse and health equity. Again, let's go back and talk about those rural communities. The emphasis on the next from 2020 to 2030 in the future of nursing is on social determinants of health. We know there are different populations, different sexes, different races that have limited access to health from others. Talking about health equity, diversity in the workforce. But wait a minute, what about health and well-being? Your health and well-being. So often, and for many years, future of nursing has been, what can you provide your patients? Well, what we've seen is that we have got to do something to retain our healthcare providers, retain our nurses and healthcare workers, and keep them as healthy as possible so they can continue to take care of these patients. So now we've seen this new escalation and new conversation about health and well-being, and I'm excited about that. Also leveraging research, education, technology, removals of barriers. So really working to move what? Full practice authority forward. Use of things like AI, the research, we need more. You know, so many things we're going to leverage over the next 10 years that truly can move our patients forward. So what challenges do we encounter as nurse practitioners? You could probably very easily say all of these things. You are spending Saturday morning here doing continuing education, and I'm so grateful and I thank you. But I also recognize that many of you have worked 40, 50, 60 hours this week already. You might have charting already waiting on you. You might have labs that you need to go review. So there are so many external pressures being placed on us as nurse practitioners. Time pressures, high demands of work. We need to see more patients in a shorter period of time. Absence of social support, lack of role clarity. One of the biggest reasons that we see nurse practitioners and healthcare providers have negative feelings toward the role that they're in and or the hospital or practice they work for is due to role clarity. Where does our role start and where does our role stop? All this external pressures that are being placed on you. And I really want to push home the most common time pressures and high demands at work. Now, what about internal? Nurse practitioners and nurses are known to be perfectionists. We are known to want to take care of others while not taking care of ourselves. And we are known to put to do the right thing at all costs, whether it affects our health, whether it affects our mental health, and whether it affects our physical health. We suppress our own needs. We feel like, and it's almost like we've been taught, we got to put everybody else first, and then you're going to take the least. You'll take what's left, and oftentimes there's not much left. Talking about role clarity, also, there's a strong need for recognition. You know, oftentimes, and I will tell you in hospital settings, so often I see nurse practitioners just when we talk about working with physicians or working for a physician group, I'll see them do all the work, but I'll also see a physician see a patient later, take over that note, the nurse practitioner's name disappears, and it's like they are being erased. And that is one of my most unfortunate parts of the work we do within hospital systems. And I really push for I push for two things. I push for one, that we be at the table and we also be the provider seeing the patient and getting that recognition. If it's just on the chart as a healthcare provider, it's important, but also recognition for what we do and the good work we do. There's a lot of physician days, but oftentimes hospitals don't have advanced practice provider days. They don't have nurse practitioner. They don't celebrate any of the things that are out there. We just celebrated back in September Advanced Practice Provider Week. That's actually new. This is the second year we've had this across the nation. So if you've not heard about it, it really brings in and celebrates nurse practitioners and PAs. We also know Nurse Practitioner Week is coming up. It's in November. and we need to be celebrating. So I would challenge you, if you're in a leadership role, make certain your institution or your group are doing something to celebrate our nurse practitioners and the work they do. I've said it over and over. If all of them decide to take off tomorrow, that's going to be a big issue within our hospital system. So we better take care of those that are bringing income into the hospital. I could talk for hours about this. Another way I see that we can help these challenges is I think that any hospital system now needs some type of a system director for advanced practice providers. Again, that puts them administratively at the table and to have representation. We recently added that in our hospital, and I am in love with our advanced systems director. She is a fierce advocate for nurse practitioners and PA. She does not take no for an answer, and she will continue to raise the concerns and the needs. So these are things that we can do to combat those things. More than anything, internally, we are feeling irreplaceable, always wanting to please others. We're suppressing our own needs. So again, it's that external and internal struggle. So how did we get here? All right, let's talk about the pandemic. And honestly, I believe that the pandemic is where we really began to see and to feel burnout and to feel what it was like. You know, it didn't take much for most of us to be at the front lines. You could be at the front lines if you were in the hospital, taking care of the most critically ill, taking care of the patients that were dying or that were doing poorly. But you could also be dressed in full gear, out at cars, outside, swabbing in clinics, right? So you were at the front lines and we felt it. It was exhausting. Just all the things we had to do to take care of the patients was exhausting. And not only that, but the mental exhaustion we felt as we left every day. Now, this question asks, has the government done enough to help alleviate our stress? You know, I don't know. And I would ask you too to say, is it the government's job to alleviate our stress? Or is it our own personal responsibility? I don't want to put it off on someone else. But what has hospitals done to alleviate stress? What are we doing to make certain we are caring for those that went through COVID? And honestly, I think you could probably all say, I still have PTSD from it. You know, I will share that I was, as a palliative care provider, I was at many bedsides as patients took their last breath. Early on, I was at the bedside because families could not be with them as they did so. And I would hold telephones as the family was standing outside the window, telling their loved one goodbye. You feel strong in the moment. You feel like you are able to just put a barrier up, but that takes a toll. And I know each and every one of you have your own stories. So I don't think that my story is the best. I don't think that my story, you know, tops everyone else. You have a story. But wow. And this says vaccines may be on the way. We know they're here. We know we have vaccines, and there's always conversations of what do we do. Another way that this pandemic really hit healthcare workers is early on, we were absolute heroes in the work. And then things began to change. And at times we began then to feel villainized, whether patients and families and loved ones even felt vaccines were appropriate, felt there was ulterior motives, felt whatever. I think oftentimes we felt in the middle. We saw the devastation that many of them didn't, and therefore they may have had some different opportunities. They may have had some different opinions, and here we are. So again, the last few years have really taken a toll on us. I would just ask you to think for a minute, what are 3 ways the pandemic has impacted your well-being? I'll share mine, and maybe not 3, but more than anything, it made me recognize that I was not infallible. I was not I was not someone that would burn out. that I was stronger than maybe I thought. It just made me much more human. It also brought into my mind the term burnout, what it meant, how I could keep going. And really, more than anything, if anyone was going to take care of me, it was going to be me. And so those were the way it impacted my well-being. And I made some interesting changes. And looking back, I think it's all in relation to the pandemic in just the last few years. And maybe it's just me getting older. You know, I've been in healthcare for 26 years. So maybe it's just the fact that I'm getting older and I'm being honest with myself. You know, you see posts that say, if you pass away tomorrow, your job will simply replace you. It won't be easy, but we can replace. But nonetheless, our families don't. So put ourselves and our time where we're most needed. And then I would ask you 3 ways the pandemic had impacted your well-being. What's worrisome to you? So begin to think about that. Interestingly enough, Medscape did some work last year, and they looked at burnout and depression. They looked at, you know, what were providers working, and this was nurse practitioners. Were they working full-time? Were they working part-time? And, you know, you might say that if you're part-time or per diem, life was much greater, things were better. But as you can see down here, part-time per diem employees, just like full-time, experienced burnout. They experienced depression. So you can see those working full-time experienced the most burnout, but it wasn't too far behind those just working part-time and per diem. It'd be nice, but again, so it's affecting us all, so we have to combat it. Looking at depression, 7% versus 6% in the full-time versus part-time employee. Of course, looking at both burnout and depression, and really none of the above, interestingly enough, was in the largest group of those working part-time and per diem. So it doesn't tell you that you're not going to experience burnout and depression, but maybe that could be the answer if you have that capability. Maybe you need to take some time, consider part-time and per diem just to help combat it. Now, I recognize that many of us cannot do that. So again, how do we move forward? Well, let's define it first. You know, could this be you? It's a state of physical or emotional exhaustion. We know physical exhaustion, we can sleep if we sleep adequately, and we can take care of that. It's the emotional exhaustion that oftentimes can be harder to combat. But this state of physical or emotional exhaustion also involves a sense of reduced accomplishment and a loss of personal identity. I no longer know who I am. The syndrome is really conceptualized with these ideas: feeling of energy depletion or exhaustion. And again, physical exhaustion absolutely exists, but it's different than mental exhaustion. Unfortunately, with mental exhaustion, if you don't physically do something, you're not, a good night's sleep is just not going to do the job. It's also an increased in mental distance from one's job. We want to be, and that can be positively and negatively, because oftentimes we think, okay, I've got to take a step back. I can't get so emotional, but yet we know our best work oftentimes as nurses come with that emotional work that we do. These feelings of negativism and cynicism often pop up related to one's job. Can you think of somebody that you're around that is very negative at all costs about every situation? You just can't make them happy if you're in leadership, or, you know, you sit down at lunch and it's the same conversation on a different day. Though that can be a definite sign of burnout. Call it out. And then finally, reduce professional efficacy. We don't feel like we're making the difference that we thought we felt like. And I think that's vitally important in nurses and nurse practitioners. So know that this phenomenon is really an occupational context, not really experiences in other areas of life. We can burn out in other areas of life, but this is really driven to where we are in our occupational professional life. So how long have NPs been burned out? Interestingly enough, many for 1 to 2 years. Now, this was done in 2022. Do the math. It really was effects of COVID. Will this look better in the next 5 years? If we do nothing, it will not. If we do something as those that work in leadership, also as those who are feeling this, then we can make changes and this number will look very, very differently. But it's interestingly to note that some are feeling this and have been feeling this for a number of years. So more or less burned out than during COVID. Well, some feel more, and during the quarantine months, some people feel that they're actually more burned out. And the majority feel that they're actually more burned out than that time of quarantine. Now, remember what was going on during quarantine. It was stressful, but in some ways, and I'll tell you, some ways that if you had older children, many of them came home. That's stressful, but it could be sometimes good. So it was almost like everybody was in one place. But where were we? We were in the hospital. We were at the office. We were still working. We worked through it all. But nonetheless, there was kind of this camaraderie with our families, I think, and many families, not all, that occurred. So I think that after the quarantine lifted, then we were still left with the aftermath of COVID, and here we are. So I think that's why you're seeing more rather than less burnout during that time. Again, quarantine was new. We didn't know what it was. We didn't know how long it was going to last. And while it was fearful, we were not at that point burned out. And so we were learning as much as we could about everything to see kind of what our life was going to look like. And I think we can all agree our life has never gone completely back to pre-COVID days. I still think about things a little bit differently in some situations than I do pre-COVID days. If you're sitting on an airplane, I fly quite a bit. If you're sitting on an airplane, what happens? Somebody coughs and everybody inadvertently and kind of gives them the eye of like, what in the world, what's going to happen? We know this is the case. It's getting better, but we're still seeing it. What contributes to most NP burnout? Interestingly enough, too many bureaucratic tasks. I was walking back to my office the other day. It was probably about 1:30 or 2 o'clock. And I remember walking back thinking, now I do things, I see all my patients, and then I'll go back and do all my phone calls to families and or all my charting. So that's just my day. A lot of people do it kind of as they go. It just doesn't work as well for me. I'm also in an administrative role, so I need to be in my office and kind of available to my employees and to everyone coming through. So that's just what works for me. But at the end of the day, I'm still about 60% clinician, 40% administrative. It feels more like 80 and 80, but I know the numbers don't match up. Nonetheless, as I was walking back, I had a drink in hand, kind of snack ready for kind of the afternoon, what it was going to look like. And I remember thinking in my head, I have 3.5 hours of work to do moving forward. It wasn't work at the bedside. It wasn't work with my patients. It was work moving forward to chart, do my paperwork, call families, but most of it was going to be those bureaucratic tasks I had to do. And I must do them. Some other reasons for burnout: insufficient compensation and salary. We still need to do a better job of increasing the salaries and compensation for our nurse practitioners and how they are paid. And we know that doesn't change everything, but it definitely helps. Oftentimes lack of respect with administrators, employers, and colleagues, and that's why I push home that I think we need system direction and we need NP leaders all over the hospital. When I took this role in the administrative role as director of operations, I felt it was vitally important to do it because I was a nurse practitioner first, not because I really wanted to be in an administrative position or leadership, but because I was a nurse practitioner first. And if you are not at the table, you are on the menu. And so I feel very passionate. I think you can tell that we've got to be there. Too many hours worked, lack of respect from patients, not as much, stress from social distancing. Again, that all occurred. And again, we're still masking periodically in different areas. So again, that stress is still there. But interestingly enough, too many bureaucratic tasks. So does it affect your personal relationships? Overwhelmingly, yes. It is very difficult to leave what happens in your day and come home to your family. We recommend you do it, and we're going to talk about ways, and we're going to speed up here. We're going to talk about ways to do it because we've got to do that. But it's clearly affecting our personal relationships. Now, how do NPs deal with burnout? It's oftentimes talking with family members and close friends. It can be isolating ourselves because why? We talk so much. We're all in or during the day at the office. And what do you want to do? You just want to come home and not say a word. Come home and try and regroup for the next day. You see others sleep, eat junk food, exercise, binge eat, alcohol. So you can see there's positive and negative things of ways people are dealing with burnout. Now, there's some we can mark here and say, those are not good ways to do it. So let's talk about how we can do it. It was an interesting quote that I heard. They described healthcare as it's like we're standing on the edge of the ocean in the dark. We're waiting for the wave to hit, and we have no idea how high the wave is going to be. We just brace ourselves. And we know we felt that a lot with COVID and even some of the, different types of COVID that came through that time. I mean, there were waves of it, but it really is how we're feeling in healthcare now. So what do we do? Let's talk about it. We have to be, more than ever, we have to be, we have to think about well-being, and we have to practice it. And we have to be there in the moment, but yet we have to be there in the moment for ourselves. We need to think about our connection and community. We need to think about our growth mindset. Where are we going to go from here? Where do you want to go? Where do you see yourself in 5 years? We want to set healthy boundaries. We want to be self-aware and know when we're feeling distress. Think about a challenge network, a group of people. We want to self-empower ourselves and finding rest in the middle of things, which we're going to talk about in a moment. So approaches, your individual approach needs to be building connections. One way we have built connections, and I'm going to talk about it, is we've started a book club in our hospital. We felt it was very important. If you look around, a lot of people are reading, and that's one of the ways I really worked on resiliency and burnout was through reading. Thankfully, after I finished my doctorate. But nonetheless, it's building those connections, being self-aware when you know either it's time to change your position or it's time to do something different. You've got to be self-aware and setting healthy boundaries. Finally, in the workplace, again, you can see all the individual processes in the workplace. We as leaders, and many of you are, need to empower leadership. We are not going to be here forever. We need to be empowering the next generation of healthcare providers coming up and empowering them to lead us. We need to be transparent. And interestingly enough, we need to be over communicating. If there's ever really stress within a lot of offices, it's because of communication. We think we've communicated it or there's misinformation or whatever. We need to over communicate. Maybe you've told them once, maybe we should tell them 3 times on different occasions about different things. Over communication is important. Building community, learning your culture, calibrating the workload. We're working on ways that we can empower our staff. I'll add another way we did this. I just changed all of my nurse practitioners' schedule to 410s. So they get 52 days extra off a year. They've been so gracious and they've been so thankful for that. So just changing a schedule has been so very important and so very helpful for self-care. It allows an extra day a week for self-care. We don't always do it, but it's there for them. Let's be intentional in the workplace. We have to be intentional now, and we need to think outside the box. There are no water cooler moments. Now, mind you, this was really the thought process around COVID. Everybody went home. Many were working remotely, not many of us, but they were working remotely. So we weren't having this camaraderie in this time of water cooler moments. We know that's changed. We know with us, it never left. But really, we have to be intentional about relationships within our workplace. It's important to have some type of work relationship, not just come and go. Now, do they have to be your best friend? No, of course not. But we just need to be intentional about our relationships. And that in and of itself can create a positive workplace and atmosphere. It can also create positivity for you. This is not fluff. I am the most guilty of this. Self-help, well-being. Over the years, I was just like, I don't need it. I am good. I've got all of that down. My friend, this is not fluff. We don't need to be taking these concepts for granted and thinking that's not me. Because if it's not you right now, let me assure you it's coming. If it's not you right now, there are other practitioners that are feeling this gravely, and we need to be looking at that and thinking about it. So find your own way to lead here. You can host a virtual happy hour. Again, that was kind of when everybody was at home, but you could still do it. Game night, dad joke of the day. We started something, and again, we're in palliative care, so we talk a lot, but we meet 3 times a week, and because we have to have, IDT meetings. But on Friday, we actually have started movie quotes of the day, or we'll have a movie quote. What movie did it come from? And we've had more fun doing that. Again, one of my ways I really felt I had to disconnect a little bit better from my workplace. I began to read. I read incessantly. I read somewhere between 10 and 12 books a month. I get that most people don't. I'm a new empty nester, and my husband travels. So I have some extra time. So I recognize nobody's doing that. My daughter, who has a new little baby and we have a new grandbaby, she doesn't have that time. She's doing some and she's finding ways, but again, it may not be your way. You got to find a way. We started a hospital book club with some of the ladies, some of our physicians and nurse practitioners and nurses. We're all getting together to discuss a book next Thursday night. It's going to be our first book club. I'm really excited about that. And I know these sound just simple, and a lot of people are like, that's not my thing. Well, find your thing and then find your people. You are doing emotionally powerful work, and it took me this long. It took me about 20 years to discover it. You can do 3 things, and the first 2 are not viable for very long. You can wall it off. Don't get emotionally involved. You'll be fine. That's really hard, but it's really easy to do, especially in palliative medicine. I call it parachuting in. I am parachuting in to many people's worst days of their life. Not every patient are we at end of life, but commonly we are. A very large stroke. They were fine yesterday. They've had a large stroke, and now everything has changed. I am parachuting into those rooms. But you know what? I've got to parachute right back out, and then I've got to give my all to that next patient. So it's easy to say I'm not emotionally involved. You'll be fine. I'm going to be fine. I don't need to know that. But you know what? That's only going to go so far, and I've learned that. You give and you give. This is where so many nurses are. Our patients are vulnerable. The suffering is unimaginable. There's not time for me, so let me just keep giving. You are going to empty that vessel out. I think we've all heard it. We've got to fill our vessel so we can empty out. And channeling, this is what I like, and this is what I teach all of my palliative providers and really all of my healthcare providers that I work with. We have a large fellowship program. We work with a lot of medical residents. We work with fellows in different specialties, and we work with advanced practice fellows. So I really teach them to be fully present in you when you are in the room. It is the worst thing in the world to be in an exam room or an office with a healthcare provider, and they are looking beyond you, and they're typing on their computer, or they have their back to you at all costs, and you never feel that they're fully present with you in the room. Again, I think I've just practiced it so long, and I'm in palliative care. It takes nothing to set your papers down and to get eye level and to listen and just listen. Silence is beautiful. So fully be present in the room. And then when you leave, you leave. Because number one, I probably got to go do the same thing in another room, or I need to go home to my family, and I'm important to them, and I need to be fully present with them as well. Are there patients that you can absolutely turn that off? No. I had a very long patient situation yesterday of a very young patient who is likely to pass away very quickly. And unfortunately, the family made the decision to take her AMA to try to take her to MD Anderson from Memphis, Tennessee. And I just am so concerned this lady is not going to survive. It was turmoil for myself, the oncologist, another provider, multiple providers had existential crisis related to it. Did I forget about this when I left? No. But you know what? We do still have to leave things. When you leave, you leave. And to be clear, really, walling it off and giving isn't going to be viable for long. So that's not a great emotional, powerful work that you're going to be doing. So how do you find rest? You need to be intentional for yourself. Paying attention that you can find rest in the middle of your day, in the elevator. Now, we're oftentimes not in the elevator long. What I mean is just take a minute between floors to breathe. Dropping into my coffee. I adore coffee. Take a minute to smell your coffee, to taste your coffee, and then move on with your day. It's little things. It doesn't have to be, I've got to have an entire week off of mental health. God sure love it. But I've got to, I've got to do that in order for this to all get better. No, we can do very little things. Change of scenery. So we have the opportunity in our hospital to go under the tunnel to get into the hospital. You are never outside. I love more than anything to walk across and walk outside for a minute. Let the sun hit me. Let the cool air, when it finally gets cool, hit me. Let the hot air hit me when it's July. But just getting that change of scenery, so very helpful. And then intentional permissions to winter for a bit. What does it mean? It is okay to be down. It is okay to struggle. It is okay to do those things, but you cannot be there forever. So you need to allow yourself to mourn things. You need to allow yourself to feel depressed at times, but we can't stay there. And when we stay there, that causes the most issue. And yes, you need to exercise, you need to meditate, and you need to take a vacation. Do whatever it takes. Take a vacation. A great book is Resilient Grieving, Finding a Way Through a Devastating Loss. This is a great book, and this was actually written by Lucy Hone, who I'm going to talk about as we begin to end this segment. Lucy Hone was a PhD psychologist, and she did a lot of work in her doctoral program on resiliency. Now, what she said was when she began her doctoral work, she is from Australia, and she went, was doing that work. And it was around the same times as the Christchurch earthquake. So she put her PhD work on hold. She began to take care of this group of, this huge group of people that were affected by this devastating earthquake. And she felt like that was her hurdle. That was what she needed to be resilient from. Unfortunately, that was not the most devastating thing. She shares that about 2 years later that they were on a family trip and her daughter got into a car with her, she was 12, got into her car with her best friend and the best friend's mother. And they all took off to, they were going to a beach together. And in the blink of an eye, there was someone that ran a red light, and all three of those people died instantly. That was Lucy Hone's rock bottom. And that's where Lucy Hone not only wrote her resiliency PhD and all her dissertation, but then she had to live it and see if it really worked. And we can all think of that. You might not have had a loved one die in such a traumatic way. Maybe you have. But have you lost a job? Have you lost a relationship? Have you ever been cheated on? Have you ever had issues with your children? Have you ever had a death of a very close loved one? Have you, there's a multitude of things. My friends, you have gone through things. So no one gets out of here without going through things. So we've got to prepare ourselves. And so I want to briefly end with 3 strategies for resiliency. We need the ability to withstand, and resiliency really is the ability to withstand or recover quickly, define it, but from difficult conditions. We don't need to stay in those, and we don't need to stay there forever. And just like we talked about wintering earlier, we can winter and we can take some time, but then how do we get back from those difficult conditions? So where do we go from here? Here's a couple of things about resiliency, and we'll finish up with her 3 recommendations in just a moment. Just some things to think about. Life doesn't get easier or more forgiving. We get stronger and we get more resilient. So oftentimes what you see, you build resilience as you get older. Resiliency is all about being able to overcome the unexpected. The goal of resiliency isn't to just survive, but to thrive. 2 of my most favorite sayings. So it really is maybe about time. Maybe it's a little bit about age, but it's about thriving, not just surviving. And you can see mindfulness awareness, self-care, professional care, and community is really how we need to mobilize resources both inside and outside of workplaces. Many of our hospitals and larger corporations, they have some type of professional care that is usually available free of charge. I recommend using this. So let's finish up with Lucy Hunt's 3 things to know about life and just her perspective. Know this: suffering is unfortunately a part of life. I'll share that with you that my husband and I, my daughter, she's been dealing with a chronic illness for 1 year. We're right at 1 year now. It was October of last year. She just developed dysautonomia from all we know from a post-COVID syndrome, but we don't know that for sure. But anyway, this is the youngest one that graduated from nursing school. She drug herself through somehow. But we've suffered, and and she suffered. Let me just take myself out of the equation. But you all have a story. Suffering is simply a part of life. I wish it weren't. It rains on the just and the unjust. You carefully choose where you're directing your attention. Your attention can be positive. Your attention can be negative. And begin to think, what am I saying? Where am I directing my attention? And what at that point is most important? And finally, is this an action or thought? Is it helping me or is it hurting me? And I love this because Lucy said she would ask herself this a lot. Is this thought helping me or harming me? And if it was harming me, she would change what she was thinking. And she said she could easily, especially late at night, she would find herself going through pictures. You know, I find myself doing research in the middle of the night. And you have to think, is this action helping me or is it harming me? If it's harming me, you know, she said she would put up the pictures and go to bed because it was not doing her any benefit. Now, some days they could look at pictures as a family and laugh and talk about the times, and that was helping them to heal. So I think it's really important for us as we go through this, as we're going through burnout, as we're trying to remain resilient. This is a great, great question. And finally, I ask you, where do you find joy? Because that's where we've got to hinge, friends. We have to hinge on where we find joy. I'll add, this is a little bit older picture. So I have to show you our edition because it's where we find joy. Let me find it because I tried to add it and then we didn't get it updated. I'm going to see if you guys can see this. Let's see. All right. I'm going to try and hold that picture up. Okay. That's our Easton. He is going to be a year old in December. And we are in love with him. And I'm sure many of you are Mimis and grandmas and all of that, and grandpas and papas and grandbuddies. But it's really important to find out where we're finding our joy. We live on about 10 acres and it has saved our lives. We love it here. We have grand dogs and they're pictured, and then we have a sweet grandson and sweet girls who are adding these boys into our family. So I just challenge you to think about, and this may not be where you find your joy. I get it, but find your joy. Where do you find it? And cling to it. And finally, success is not final. Failure is not fatal. It is the courage to continue that counts. Whew, so take a deep breath. We've got this. In summary, we've pushed home. There is going to be a shortage in healthcare workers. I don't hesitate to tell younger people, go into healthcare. We need you. And we need you at the bedside. I so often have many young students say, I want to be a nurse practitioner. I want to be a nurse practitioner. And I am thrilled about that. You know what? We need nurses, and we need them at the bedside, and we need them in clinics, and we need them in all the places we need them. We need nurse practitioners as well. We know that NPs and PAs are among the most in-demand health professionals. And we know we're moving constantly toward full practice authority in other states. So I challenge you to think about burnout, think about resiliency, because we need you. We need you to stay here. We need you to stay intact, and we need you to stay with us. And so I hope this hour, it did nothing. It cheerleaded you on to where we are and where we're going. So please keep doing what you're doing. Thank you for what you're doing. All right, so post-test polling questions. These are the fun ones. What's the estimated shortage of U.S. healthcare workers expected by 2026? Up to 2.5 million, up to 3.2 million, up to 4.1 million, up to 4.7 million. Answer now. Very good, up to 3.2 million. You're right, pre-test, post-test, they help. So that's great to look at. So yes, 3.2 million. We need people. We need people. How many states in the US have full practice authority for nurse practitioners? 19 in DC, 27 in DC, 33 in DC, all 50 in DC. (27) in DC, you heard that right. The results of the 2022 survey indicate the current level of burnout compared to that during COVID-19 quarantine was lower, similar, or higher. It was higher, absolutely. The Veterans Affairs Circle of Resilience includes self-care, seeking professional care, and which of the following? Calibrating workload, adopting a growth mindset, setting healthy boundaries, and reflecting on values. Setting healthy boundaries got the most. Yep. All right. So let's move on. And I want to very briefly take some questions because I know that I've gone over a little bit. Most people are being kind. Thank you. I saw somebody just mentioned, I think you need to add the role of faith in coping with stress and burnout. I could not be more agreeable about that. You're exactly right. We really do. It plays a role. And it plays a role greater in some people's lives than others, but absolutely it plays a role. The other person says, I encounter people who are aging and this is their grief. Any thoughts on aging patients? You know what? I say this all the time to my aging patients, especially my palliative patients that are really dealing with, these major issues that come up with an aging population. And I always just go in and more than anything, offer myself and I come up alongside of them. And I always say to them, aging isn't for the weak, is it? And they love it. They love just to be heard. We can't take away, what's going on and what's going on with their body. But what we can do is truly come up alongside them. And I always tell them that. They always chuckle and say, "You're right, it's not for the weak." And I'm like, it's not for the wimp either. And they love it. So I think just listening, allow them to talk, and then look for ways that you can help them. We can't take that away often. And finally, it says, "I am a disabled NP. I haven't worked in years because of it. Is there a nursing organization or recommendations you know of that could help me get back to work? I need funding for a refresher course or additional education." I always tell you to first, more importantly, start with your local nurse practitioner, advanced practice association groups. There's usually one in a larger area near you. That's a great place to start. And also, I'll tell you, social media is a great place to start as well. Just put the information out there, and you will be surprised how many people are in your same situation and things like that, of things they've done. So definitely reach out in social media sites, and also to your local association, your local associations as well. All right. Well, let's stop there. And I see Miss Martha. Hello. We got to work together last year, and I'm so excited that Martha is back again this year. So hopefully you can stretch very quickly and then jump right in, because I don't want to take her time, and I've taken enough of her time. I totally get it, and I apologize. So Martha Kingman is a family nurse practitioner working in Pulmonary Hypertension Comprehensive Care Center at the University of Texas University of Texas Southwestern Medical Center in Dallas since 2000. She earned a doctorate of nursing practice from Texas Christian University in 2011. And you can also see the rest of the information about each speaker up in our agendas as well. And I don't want to take her time, so find out more about Martha. But I want to get out of the way and let Martha start. So thank you so much, Martha.
Thank you for having me, and I really enjoyed your session.
Thank you.
Okay. I am not seeing the slides.
Oh, did you click on the link?
I did. When I signed in initially, I clicked on it.
Okay. We might need to pause for just a moment.
Okay.
So yeah, everybody, please
Okay, hello, and everyone, sorry for that little technical glitch that we had, but welcome to the program. And our title today is called Exploring the Nurse Practitioner Continuum of Care with regard to assessing, diagnosing, and managing pulmonary arterial hypertension. There we go. This is my title, which we've already gone over. These are my disclosures. And these are the learning objectives for this session. We're going to talk about the signs, symptoms, risk factors for pulmonary arterial hypertension. We'll talk about patients who would benefit from early referral to a specialized center. And we'll talk about how we design treatment plans and how we utilize current therapies and touch a little bit on the emerging therapies for pulmonary arterial hypertension. So we're going to start off with talking about how we define this disease and some of the epidemiology. This is when we're talking about this disease today, we're talking about pulmonary arterial hypertension, and you may hear me call that PAH for short. And PAH is a very rare disease. It affects about 1% of the global population, and there's only 500 to 1,000 new cases each year in the United States. And within the group of pulmonary arterial hypertension, about half of them are idiopathic, meaning, of course, that we don't know what's causing it. We do know that this disease is much more common in women than men, 3 to 5 times more common, as a matter of fact. In the age group, is usually between 30 and 60 at the time of diagnosis. It used to be younger. Now we're seeing older patients. It does occur, though, in all sexes, all ages, and there is a form in infants, or it's called newborn pulmonary hypertension. And we are not going to discuss that today. I'm having trouble with my slides. Okay, so pulmonary arterial hypertension is diagnosed in the cath lab by having a right heart catheterization. So the definition of PAH is a hemodynamic definition. And if you look at the box on the left, that's the older or the historic definition of pulmonary arterial hypertension. You'd have to have a mean pulmonary artery pressure, 25 millimeters mercury or higher. The pulmonary artery wedge pressure had to be less than or equal to 15, and that reflects the left-sided heart pressure. And then the pulmonary vascular resistance, which is a calculation, had to be over 3 Wood units. And we had that definition from the 70s, I think 1972 or so, up until 2019. So it's pretty recent. We have had a change in the definition of PAH, which is in the box on the right. Now we define pulmonary hypertension if the mean pulmonary artery pressures over 20 rather than 25, so we've lowered it. And the pulmonary vascular resistance now only has to be above 2 Wood units rather than 3, and we still have to have normal left-sided filling pressure, so the pulmonary artery pressure. Now, if you look at the box above there, the red box, it's just an overview of what happens in this disease. And with pulmonary arterial hypertension, as I'm going to show you, there's changes in the pulmonary vasculature, which results in narrowed pulmonary arteries. Then you have a right ventricle that's working very hard to get blood through the pulmonary arteries over to the lungs. And eventually, over time, the right ventricle can't keep up that workload, and then patients start to develop right heart failure, and then ultimately will die from right heart failure. And this is just a visualization of what happens. On the left is the pulmonary artery, and this shows the remodeling that we see in this disease. And basically, the medial and intimal layer of the pulmonary arteries become thickened and fibrotic. And if you look in the middle section, it's sort of a cross section of the lumen. On the left, the lumen, or that dark red part, is pretty wide open. Blood is flowing easily over to the lungs. And then on the one next to it, the vascular obstruction is when these blood vessel walls are thickened. Now we have a narrowed lumen, a right ventricle working hard. On the right is the right heart, what changes that occur in pulmonary arterial hypertension. And you can see that the blood vessel wall, or I'm sorry, the right ventricular wall is hypertrophied and enlarged. And eventually it gets so big that it's the septum in the middle starts to bow over into the LV. That's what it looks like on echocardiogram. On the left is a normal echocardiogram. And if if there's anyone in the audience not familiar with echocardiograms, just to orient you, they're upside down and backwards. So at the top are the ventricles, and on the left is the right ventricle, and on the right is the left ventricle. So you can see then in the normal echo that the right ventricle is smaller than the left ventricle. That's normal, that's what we like. But in pulmonary arterial hypertension, the right ventricles get so big that they become bigger than the left ventricle, which you can see on the right. Now, this slide is a very important slide, probably the most important slide of the whole deck. So I do need to spend a few minutes on it because it's often confusing, this term pulmonary hypertension. Pulmonary hypertension is an umbrella term, and under that umbrella, there are 5 different types. In pulmonary hypertension, we call them groups. So we have group 1, group 2, group 3, group 4, group 5. The remainder of our attention during this session is on group 1, which is pulmonary arterial hypertension. What we just described is being very rare. Then group 2 is another form of pulmonary hypertension. And on the right heart catheterization, in these cases, you would see a high pulmonary artery wedge pressure, meaning the left-sided filling pressures are high. It makes that mean pulmonary artery pressure come up, but it's a completely different disease state. And we call that group 2 pulmonary hypertension from left heart disease, and is very common. For every 10 right heart caths that we do, 8 of them will be group 2. The next group of pulmonary hypertension patients is group 3, and that's patients who develop high pulmonary artery pressures due to hypoxic lung disease. Most often, it's advanced interstitial lung disease or advanced COPD, and the hypoxia itself causes vasoconstriction, causes the pressures to go up. And then group 4 pulmonary hypertension is also very rare. It's called CTEPH, which is chronic thromboembolic pulmonary hypertension. And it occurs in patients who have had pulmonary emboli that have become chronic. So rather than narrowing of the pulmonary arteries, like we see in group 1 pulmonary hypertension, in CTEPH, group 4, we have blood clots that have not resolved and are blocking blood flow over to the lungs. That's what causes the pressure to go up. And the treatment for them is surgery to remove those clots in most cases. And then group 5 is where we put all the things that we know can cause pulmonary hypertension, but they haven't been well studied, and there's no treatment guidelines for them. An example might be end-stage renal disease or sarcoidosis, sickle cell anemia causes pulmonary hypertension. We put all those in group 5. So we've got 5 different types. One last comment on group 1, the PAH that we're talking about. You may also hear that referred to as pre-capillary. So it kind of has a lot of names, this PAH. Okay, so within pulmonary arterial hypertension group, we have subtypes. The first one being idiopathic, I mentioned already, makes up about half the cases. Then that's 1.1, and then 1.2 is heritable, makes up about 6% of the cases, pretty rare. Those are patients who have a gene mutation that's passed along to family members, usually multiple family members, called the BMPR2 mutation. There's other mutations, but that one's most common. And then 1.3 is the group that's associated with drugs and toxins. And this is where people have usually heard about pulmonary arterial hypertension, because there was a drug, a diet drug that was on the market in the 1990s called fen-phen, and that led to the development of pulmonary arterial hypertension. It also caused valvular heart disease and was taken off the market. Other drugs in that category, the most common one is methamphetamine. And we do see a lot of patients that use methamphetamine and develop PAH. And then there's some others that are very infrequent, dasatinib, for example. So 1.4 makes up the remainder of the PAH patients, and that's associated with other conditions. So patients who have, for example, here listed here, connective tissue disease are at risk to develop PAH. And within connective tissue disease, scleroderma is by far the most common. HIV can also cause PAH. Portal hypertension, those are patients who have cirrhosis, get portal hypertension, and then develop what we call portal pulmonary hypertension. Congenital heart disease is in group 1, PAH. It's usually simple shunts, ASDs or VSDs that have not been repaired. And then schistosomiasis is a parasitic infection that occurs primarily in Asia and Africa. I've only seen it one time in 24 years in a patient who had traveled. And then the other ones, 1.5 is pulmonary veno-occlusive disease, falls in PAH. We won't touch on that too much. It's very, very rare. And then persistent PH of the newborn falls in group 1 PAH. Now, in the 1980s, the National Institute of Health collected survival data, and this is in the pre-treatment age. So there was no treatment. They just basically recorded when a patient was diagnosed and when they passed away. And that at that time, the average survival was 2.8 years. And now that we have treatment, we have a better survival, but still fairly poor, very poor, actually. There's about 70% of patients alive at 5 years. And so we usually say 5 to 6 years is our average survival now. We do think that if patients are diagnosed earlier and started on treatment earlier, that they have a better survival overall. On the right, the box just says therapeutic strategies include specific medications for PAH. We're going to talk about those. Calcium channel blocker responders are very rare. In the essence of time, I'm not going to go into that. And then when all medical therapy options fail, then we refer patients for lung transplantation. So if you're a nurse practitioner working in a PH center, like I am, we have a lot of hats that we wear, just as you all do in all of your jobs, I'm sure. A lot of interaction with family, education of the patients, and also other staff members and hospital employees and so on. A lot of time is spent monitoring the disease progression and initiating treatments, managing side effects, all kinds of things. Fortunately, in our clinic, we have nurses who do all of our insurance approvals, the prior auth. So we're very fortunate in that regard. I don't have to do that. So we're going to enter into a case study. This is Rachel. She's an African-American woman, age 32, and she presents to your clinic with shortness of breath over the past 4 months. She also feels lightheaded when she climbs up the stairs. She doesn't have any chest pain, syncope, or palpitations. And importantly, she was diagnosed with scleroderma 9 months ago. So first question, other than the presence of shortness of breath, what's the biggest clue that Rachel might have PAH? 1, the duration of her dyspnea, being female in the right age group, being unusually fatigued, or having scleroderma. All right, and here are the results. Excellent. Okay, we'll talk about them in just a moment. So you all did very well, but the presence of scleroderma should be a big red flag that if you have a patient with scleroderma sitting in front of you and they're short of breath, you should suspect pulmonary arterial hypertension. Other connective tissue diseases, though, can also cause it. Lupus, Sjogren's, mixed connective tissue disease, even rheumatoid arthritis. If you have scleroderma, though, you have a 33% chance of developing PAH. The other things other answers that were listed there are true, but they weren't the most compelling reason to suspect PAH. The duration of dyspnea, for example, doesn't matter. Some of our patients are short of breath for a month. Others will come to us, they've been short of breath for years. She is a female in the right age group, but there's a lot of things that affect young women, right? And then fatigue is such a vague, non-specific symptom that would not necessarily make you think about PAH. Okay, so next question, according to the REVEAL Registry of United States patients with pulmonary hypertension, how long does it take on average for a patient to receive an accurate diagnosis of PAH? And I want to caveat here and tell you this is a data set that's pretty old, the early 2000s. So hopefully it's better. But at that time, here's the answers: 9 months, 18 months, 24 months, or 34 months. All right, so kind of all over the board. Only 7% of you thought it took 34 months. Actually, it did during that time frame, took 34 months for a diagnosis to be made from the time the patient first presented with symptoms until they got an accurate diagnosis. We don't have more current data on this, but the data that we do have suggests that it's still pretty close to that, unfortunately. We do a lot of education about early diagnosis, and we still are taking too long to diagnose these patients. All right, so we're going to move on to the detecting and diagnosing pulmonary arterial hypertension. Clinically, what we see is most commonly shortness of breath on exertion that worsens over time. That's by far the most common symptom in multiple registries. And then that's followed by fatigue. So our patients are short of breath, they're tired. Dyspnea when they bend over, or lightheadedness when bending over, is really common. They can have palpitations. Hemoptysis is not listed here, but not super common in my experience. I've seen it, but not very often. And I also haven't seen this much either, but did show up in the registries of exercise-induced abdominal pain and nausea. Weight gain due to fluid retention, super common. What I spend probably the majority of my time doing is managing volume overload. And then syncope happens when the disease has progressed so far that there's a decline in the cardiac output and patients get low blood pressure and they start having syncopal events. And that is a very, very late sign and a very concerning sign. And they list some rare symptoms that can happen. The only one really probably worth mentioning is this hoarseness, this dysphonia. I've seen this a few times. And that's because the pulmonary artery gets so enlarged that it affects the phrenic nerve, I believe is the nerve that gets affected, or the laryngeal nerve, I'm sorry. And then the patients get hoarse. I think in 24 years, I've seen that like 3 times. So pretty rare. We talked about the WHO group classifications of pulmonary hypertension being super important. We also classify patients by functional classification. And really, this is just a description of how short of breath or how symptomatic the patient is. If you treat heart failure by any chance, it's the same system. It's functional class 1 through 4. Functional class 1 is a patient who doesn't have any symptoms. We don't have any of those patients because they haven't presented without symptoms, but sometimes we're able to get patients to functional class 1, or maybe they get diagnosed incidentally. Functional class 2 patients can do their normal activities without shortness of breath, but if they try to go up more than 1 flight of stairs or exercise, they'll feel short of breath. Our goal is kind of to try to get everybody to functional class 2. Functional class 3 are where more of our patients are. They're short of breath with their activities of daily living, 1 flight of stairs, pretty much any exertion. And then functional class 4 are the sickest patients, or the most advanced patients, and they have shortness of breath, sometimes even at rest. If they're having syncopal events, they're functional class 4. They've got right heart failure signs and symptoms for sure. One note to make is that it's not always you're a functional class 1, 2, 3, and then you're 4, and then you die. Oftentimes somebody's functional class 4, we get into a 3, and then they might go back to a 4. If they're really lucky, they get to a 2. So it's this fluid thing that goes back and forth. Because sometimes patients see this and they think it's like a staging, and it's not necessarily the case. All right, so in 2022, the European Society of Cardiology and the European Respiratory Society updated the pulmonary hypertension guidelines. And you might say, what does that have to do with us? That's Europe, but we do follow the European guidelines. They were updated last year in 2022, and they tried to simplify the diagnostic algorithm. And it begins with a suspicion of patients that may have pulmonary hypertension, for example, a scleroderma patient. Fast track them to the pulmonary hypertension center. And I'm going to show you what this algorithm looks like. And I kind of laughed with the title of this saying simplified because it looks very busy, but it's actually is pretty simple. The process on this algorithm starts with a general practitioner at the top, and they're doing, you know, the usual things: physical exam, medical history, getting some lab results, checking their oxygen saturation. And then generally the primary care doctor will suspect, okay, I think this is a lung problem, or this is a heart or pulmonary hypertension problem. And then they go down these algorithms. So on the left, if they're suspecting lung disease, they would get pulmonary function tests, maybe high-res CT, chest CT, those kinds of things. And then if they do identify a cause for that, great, take care of that cause, you're done. If not, you may need further workup. Now, on the other side, if they of this algorithm with a PH or cardiac disease is suspected, patients should then have an echocardiogram. Anytime pulmonary hypertension is suspected, any kind of pulmonary hypertension is suspected, the starting point is an echocardiogram. And then from there, you look at the probability of having pulmonary hypertension based on that echo. And if you had an echocardiogram that estimated the pressure very high, the right ventricle's enlarged, you got right ventricular dysfunction, those are super big flags. The patient may have pulmonary hypertension. You need to send them to a pulmonary hypertension center. And on the far right at the top, it says fast track. So anytime you think you have very likely someone, you don't need to waste time with any of this algorithm, just get them to the PAH center. So once in the pulmonary hypertension center, these are some of the things that we do. We do the right heart cath and make the diagnosis, and then we start therapy based on that. And I'll show you the treatment algorithm here in a minute. Brett was talking about palliative care. We do try to start palliative care pretty early on in this process. Multidisciplinary team meetings is the second thing listed there. At UT Southwestern, we do weekly case conference where we have a multidisciplinary team that goes over all difficult cases. Anybody has a question about a case, they bring it to the meeting. Patient empowerment and advocacy, that's often done at most PH centers through having patient support groups. We have two, one in Dallas, one in Fort Worth. Interaction with other healthcare providers, we do try to keep that relationship with the primary care doctor open and communicating well. Many of our patients come from very far away, so we need the local people to help manage these patients. And then there's quality control audits. We do a lot of, just database collection on our patients. And then the last one being research. And we are involved in many research trials, and we try to get eligible patients into clinical trials whenever we can. Regarding lab results, we always get a CBC and a CMP, so usual stuff. And then we draw some serologies looking for autoimmune diseases. We also, not listed here, is we also check HIV on all of our patients because that can be a cause, as we talked about earlier. And then on imaging, it says CTPA. It's not something that we do in our practice, which would be a CT of the pulmonary artery. Oh, no, maybe this means CT pulmonary angiogram. I apologize. It's not usually the acronym I use, but it lists CT, pulmonary angiogram, and VQ scan, because those are tests that we do to evaluate if a patient has CTEPH. And if we have a patient with pre-capillary pulmonary hypertension on right heart cath, every one of those patients has to have a VQ scan. It's a gold standard in all the recommendations, and that's because that's the test that can see if a patient may have chronic unresolved blood clots and therefore have CTEPH. In order to have CTEPH, you have to have pulmonary hypertension and a VQ scan that has at least one perfusion defect. All right, so the way that we follow our patients over time and evaluate how they're doing and if they're progressing or if they're stable is by doing a process called risk assessment. And there are multiple risk assessment tools that are used. Two of them are listed here. The one on the left is the Reveal 2.0, and it has 13 variables within this calculator. And I will tell you that it takes a little bit more time, and most of us are using the one on the right, which is Reveal Lite. And there is a typo there that I apologize, I did not catch. It should be Reveal Lite 2.0. As far as I know, there is no Reveal Lite 2.22. So I'm not sure how that happened. But anyway, this is a simplified, abridged version of Reveal 2.0 called Reveal Lite 2.0. And it has just 6 variables that we look at. And we look at their functional class. It includes systolic blood pressure and heart rate, the 6-minute walk test distance, their NT-proBNP or BNP levels, and whether or not they have renal insufficiency. You plug these things into the calculator, and then we're able to tell if a patient is low risk, intermediate risk, or high risk, and that means for dying in the next 12 months. This is another assessment, risk assessment tool. This is the ERS ESC 3 strata risk assessment tool. And in the European guidelines, this is recommended for use when a patient is first diagnosed. And it does look like a very busy slide or table, but actually we can make it pretty easy. On the left, the determinants of prognosis are listed there. Clinical signs of right heart failure, progression of symptoms, whether or not they're having syncope, what's their NT-proBNP level, their hemodynamics, and so on. All of those things in registries have been associated with a patient's prognosis. So that what you do is you look in these 3 columns to the right, low risk category, green, great. That's where we want to get everybody. Intermediate categories in yellow, and then the high risk patients in red. And you can see high risk means you have a risk of death over 10%. So you just go through these determinants on the left and you look to see where they fall. For example, 6-minute walk distance halfway down there. If it's 200 meters, they get a check mark in the intermediate risk. If it's less than 165, they get a check mark in the high risk. So you just go through and see where the patients fall. And sometimes they have indicators in different categories. So you have to kind of look at where the majority of them are falling. This is a 4-strata version of that table I just showed you, and it is used for follow-up visits. So the initial visit used a 3-strata, and then after that, we switched to the 4-strata approach. And what they did with the 4-strata is they just split the intermediate group into intermediate low and intermediate high. And the reason they did that is because 70% of patients were falling in the intermediate group. And they were quite different. You could have an intermediate that was kind of like doing pretty good, and then an intermediate that was almost to high risk that was a completely different patient. So we're really happy, I know I am, that they split that group up. So they just took the parameters within each one of the intermediate category, cut them in half, and made an intermediate low and an intermediate high. This is just a table showing recommendations for monitoring patients overall. This is also from Europe. It lists the stuff that the testing that should be done on baseline. Everybody should have their functional class assessment, 6-minute walk, a right heart cath, of course. Most important, one of the most important things to take home from this presentation is don't ever think anyone can make a diagnosis of PAH without a right heart cath, because if they do it on echo, they're going to be wrong 50% of the time. So moving over, the 6-minute walk test, it's recommended every visit, really every 3 months. We do the 6-minute walk test. Echoes, they say every 6 to 12 months. It varies by center. We usually do ours once a year. Unless there's some uncertainty, we might do it in 6 months. And then the right heart cath, of course, at baseline. And then the recommendation there is every 6 to 12 months. This has more recently been sort of shifted to when a patient's diagnosed, they have their right heart cath, we start therapy, and then 3 months later, we do a right heart cath again to see what their risk assessment's looking like and whether if they need to have their therapy advanced. So we don't wait 6 months to do that. In risk assessment tool, no matter what tool, I showed you 3, there's more than that, but all of them include some of these measures. So they all will have a biochemical marker, an NT-proBNP or a BNP. They'll all have some measure of clinical assessment, whether that's functional class or signs of right heart failure, or they have syncopal events. They'll all have some measure of exercise capacity. In our program, in most programs, we do 6-minute walk tests. It's just easier, but there are places that do CPATs on a regular basis. And then all the risk assessment tools will have some measure of echocardiographic evaluation, right atrial area and presence of pericardial effusions are both associated with poor survival, worsening survival. And then measures on the right heart cath, the hemodynamic evaluations, cardiac index, right atrial pressure, and mixed venous sat being the things that correlate the most, the strongest with survival. So that was kind of a quick overview of PAH, and we're going to talk now about the treatments that we have approved by the FDA, and then after that, we'll talk a little bit about emerging therapies. The goal for therapy with these medications are to improve their hemodynamics, to improve their symptoms, improve their exercise capacity. Those are what's really important to the patient. They want to be able to get out and do things and get their life back, improve their quality of life. And with our medications, some of them can prevent clinical worsening. We hope to prevent hospitalizations, because when patients are hospitalized with PAH, it worsens their prognosis. And then ultimately, of course, we hope to improve their survival. Our overall goal with treatment is to get patients to low risk status on those calculators that I showed you. If they're intermediate, that's not good enough. We need to do something else. We'll do everything we can to try to get them to low risk. They have a much better prognosis if we can get our patients to low risk status. All right, so we'll touch on these medications that are approved to treat PAH. We have 14 of them now. The first class there, the first row, are the ERAs, that's endothelin receptor antagonists. There's 3 of them: ambrisentan, bosentan, and macitentan. All of them can cause a little bit of lower extremity edema, so we have to watch for that and often increase our diuretics. Bosentan has a black box warning for liver injury, so they require monthly liver function testing. So we don't use that anymore unless insurance just demands it. Also, ERAs all cause birth defects. So they have a REMS program, and all patients have to enroll in the REMS program. The providers have to enroll. We have to all say we're working very hard to make sure the patient doesn't get pregnant. The next column is a soluble guanylate cyclase stimulator. And the one below that is the PDE5 inhibitors, and they kind of follow in the same pathway, but so we would only use one or the other. The soluble guanylate cyclase stimulator is riociguat. It's an oral therapy as well. It's approved for group 1 PAH and also the CTEPH patients, group 4. If they've had surgery and they still have pulmonary hypertension, you can use riociguat, or if they're not surgical candidates, meaning the surgeons don't think they can get those blood clots out, then we'll put patients on riociguat. The PDE5 inhibitors, as most of you are probably well aware, are more commonly used for erectile dysfunction. We use them to open up pulmonary arteries. And there's 2 that are approved: sildenafil, which is the same as Viagra, and tadalafil, which is the same as Cialis. And these are oral formulations or IV formulations. We don't use them, but the most important thing here is that patients can never take any form of nitroglycerin while they're on a PDE5 inhibitor, because it can cause profound hypotension. And I should have also mentioned that riociguat causes birth defects as well. So monthly pregnancy testing, 2 forms of birth control for our patients. The prostacyclin pathway, or the prostacyclin medications, are our most potent medications, and we have multiple options in the prostacyclin pathway listed here. Epoprostenol was the first drug that we had approved by the FDA, and that was approved in 1995. And then we had another form of that in 2008, but they're listed here. Iloprost is an inhaled prostacyclin, and then treprostinil is given in multiple different ways: orally, IV, subcutaneous, and by inhalation. And the last one there is a prostacyclin receptor agonist, which is a little bit different, but acts the same as the prostacyclins, has very similar side effects. It's a pill. It's called Selexipag, or Uptravi is the brand name. We'll talk about some of the newer things that have happened here lately. Last year, the Tyvaso, or treprostinil DPI inhaler, was approved, and treprostinil, under the brand name of Tyvaso, has been around for a long time. It's an inhaled prostacyclin, but this study, the BREEZE trial, looked at using this in a DPI rather than a nebulized approach, and that was a successful trial. Now we have a DPI, so patients can use Tyvaso in DPI or by this nebulizer. Oops, sorry, advanced too far. There's some advantages to giving patients a prostacyclin by inhaling it, because it gets right into the lungs where we want it to be. We don't see as many systemic side effects. It can potentially help in patients who you're concerned might have VQ mismatching. And it does have rapid absorption into the bloodstream. Now, disadvantage is this irritant effect that it can have on airways and cause cough. And coughs are #1 side effect with the inhaled therapies. Occasionally leads to discontinuation, but most patients just have to live with this cough whenever they do the treatment. All of this can be very costly. I would say that's true of all of our medications except the PDE5 inhibitors, which have gone generic. These are the pathways. There's 3 of them that all of our medications target. On the left is a nitric oxide pathway. And just in the interest of time, I'm going to try to make this a little bit quicker. Within the nitric oxide pathway, we have the PDE5 inhibitors and the soluble guanylate cyclase stimulator. They are vasodilators. In the middle column is the endothelin pathway. And endothelin levels in patients with PAH are very high, and endothelin causes fibrosis and vascular hypertrophy. So what we do with these drugs, the endothelin receptor antagonists, is we block the receptors for endothelin A and B, and that prevents the blood vessels from constricting. And then in the third pathway, the prostacyclin pathway, that's our most potent pathway. These are very powerful, potent vasodilators, and potentially have some anti-proliferative effects as well. All right, so the guidelines have changed based on some dual therapy trials that a number of years ago were very convincing. So the recommendations now are for newly diagnosed patients with low or intermediate risk that should be started on 2 drugs, and that's an endothelin receptor antagonist plus a PDE5 inhibitor. And that's based on the results of a very important pivotal trial we had in pulmonary hypertension called Ambition. This is what it looked like. Patients were randomized to receive either monotherapy with ambrisentan, which is the ERA, or monotherapy with tadalafil, the PDE5 inhibitor, or both. So they followed these patients over time and found a significant decrease in the patient's number that had worsening events in the patients that were treated with ambrisentan and tadalafil. The green monotherapy means they just put all the monotherapy patients there together. So on the vertical axis is patients without a worsening event. So this was statistically significant and convinced all of us who were already doing this anyway at this point, but it gave us the data to show that patients by far do better if they're started on 2 drugs upfront versus 1. That led us to think, well, maybe 2 drugs are better than 1, maybe 3 drugs is better than 2, which led to the Triton study. And this looked at triple therapy versus dual combination therapy. And basically, they had patients that were on macitentan, a different ERA than Ambition used, but an ERA and a PDE5 inhibitor, and plus selexipag, which is oral prostacyclin agonist that I mentioned, or macitentan and tadalafil in placebo. And I'm not going to get into all of this again for the interest of time, but this was a negative study. It was surprising. We all thought 3 drugs has got to be better than 2, but they were not able to show it. The primary endpoint was the change in pulmonary vascular resistance. There was no difference between the groups. There was no change in 6-minute walk, and there was no change in NT-proBNP. The only thing they were able to find on secondary analysis, which again was not a primary endpoint, that there was a reduction in disease progression if you started patients on triple therapy. So negative study, we'll say caveat, if we have somebody that comes to us in frank right heart failure and they're dying, we're going to put them on all 3 drugs, regardless of the study result. This is the treatment algorithm, again, updated last year in 2022 in Europe. And it starts with diagnosis being confirmed at the Pulmonary Hypertension Expert Center. General measures are initiated, which oftentimes include oxygen or diuretics. And then it splits into two sides. On the left side is patients without comorbidities. And it basically means you think you have really a group 1 PAH patient for sure in front of you. You do the risk assessment using the 3-strata model. And then if they're lower intermediate risk, they're started an ERA and a PDE5. If they're high risk, they get an ERA, PDE5, and consideration of IV therapy. At follow-up, which should be 3 months later, you do the risk assessment using the 4-strata model. If they're in low risk status, the green box on the lower left, great, they're where they need to be. You don't need to do anything different. If they're intermediate low, you can consider adding an oral prostacyclin, or sometimes we add an inhaled prostacyclin in that group. But if they're intermediate, high, or high risk, if they're not already on IV therapy, and by IV therapy, I mean continuous infusion 24/7, just in case you weren't aware of that, and then evaluate them for lung transplant. Now, if they happen to fall over on this right-hand side where it says patients with cardiopulmonary comorbidities, that means you have a patient at a precapillary setting on the right heart cath, but you still think they might have some group 3 or group 2 pulmonary hypertension. There's certainly a lot of that mixed stuff that we see. In that situation, the recommendation is to start with monotherapy and then closely follow them to see if they need the second drug. Because in rare cases, if you have somebody who, well, maybe not rare, in some cases, if you have a patient that has significant group 2 pulmonary hypertension, then you give them our PAH drugs that can potentially make them worse. So that's why we, in those situations, start with monotherapy. All right, so we'll move on and talk about some of the things on the horizon. There's a lot of excitement in pulmonary hypertension right now. This first one is the Merck study looking at an inhalable soluble guanylate stimulator. So similar to riociguat that I talked to you about, but this isn't a different one, but it's inhaled. This second line is this ADUI study that's ongoing now. All of these are ongoing, by the way. They're all enrolling patients now. And it is using a combination pill. So they've created one pill that has macitentan and tadalafil in it. And the hope there is, patients can hopefully be more compliant if they only have to take one pill versus 2. And then ralinepag is in the advanced study. It's a prostacyclin agonist as well, similar to selexipag that I mentioned to you, but potentially has a longer half-life. So we're hoping it might be able to be dosed once a day. So that's the advanced study with ralinepag. Seralutinib is another study that's under investigation. It's a PDGFR antagonist. It's an inhaled medication. And then the last one listed here is sotatercept. And their secondary in their third clinical trial have already been finished. And I'm going to talk to you about those in a second. But these are sub-studies that are being looked at in sotatercept. Zenith, Soteria, that's their long-term open-label extension. Hyperion, Moonbeam is looking at sotatercept in children. Sotatercept is a subcutaneous injection that's given every 21 days. And this is the ADUI study, actually. This is the one that's got the combination pill with the ERA and the PDE5. So if you look at the blue bar, this is change in pulmonary vascular resistance. We want that to go down, obviously. The lower the PVR, the better. So the group with the combined pill did better than the macitentan group alone, which is the green group. And then the combined pill did better than the group that was only taking tadalafil. So those were good results. We expect hopefully that to be available at the end of the year. And Pulsar is the phase 2 study of sotatercept. And this was a really big deal and continues to be a really big deal in our space. This phase 2 study was looking at the pulmonary vascular resistance change. They studied 2 strengths, 0.3 milligrams per kg or 0.7 milligrams per kilogram, again, sub-Q injection. And you can see the decrease in the pulmonary vascular resistance with sotatercept at both strengths, more so in the 0.7. So they decided to move on to phase 3, which they've completed now, which is Stellar. This is very encouraging. The primary endpoint was a 6-minute walk test. And the blue line there are the patients that took sotatercept. And then this is sotatercept added on to background therapy, and most commonly ERAs and PDE5s, although some patients were also on prostacyclins. And then the gray line is the patients that did not that received placebo rather than sotatercept. And so there was a 54-meter improvement in 6-minute walk test, which is huge for our clinical trials. And then they had 8 of 9, or really 8.5 of their secondary endpoints were positive. So everyone is very, very excited about this drug. It will be the PDUFA date with the FDA is March 26 next year. So it should be hopefully on the market next year. And patients are very excited about this. Soteria, again, that's just their long-term extension study. They had they did do some initial late breaking news or updates at ERS 2023, and they were showing that these patients with sotatercept in the long-term study still had improvements in their walk tests, their NT-proBNP, their functional class at 1 year. As far as side effects, there were 23% of patients had telangiectasias. None of them were serious, but we've never seen this in any PH drug before, so it's kind of interesting, 23% having those. There were 7 patients that experienced clinical worsening events, including 3 deaths and 3 PAH-related hospitalizations. And the median exposure as of that point in Soteria was 336 days. TORREY is the phase 2 trial of seralutinib. That's the inhaled PDGFR antagonist that I mentioned. They enrolled 86 patients with functional class 2 or 3 pH. They met their primary endpoint, which was change in pulmonary vascular resistance at 24 weeks. The functional class 2 patients had a 14.3% PVR reduction over placebo, and the functional class 3 had a 20% decrease in their PVR. There were not very many side effects. There was some mild to moderate cough. This is the phase 2 trial of ralinepag. This is a prostacyclin receptor agonist. There were 61 patients that were enrolled, functional class 2, 3, and 4. They met their primary endpoint as well, which is change in pulmonary vascular resistance over 22 weeks. Patients on ralinepag had a 29.8% reduction in PVR over placebo and an increase in walk by 32 meters with ralinepag versus placebo. This is this long-acting, potentially once a day pill that's a prostacyclin agonist. The side effects that were most common were headache, nausea, and diarrhea. That's what we see with all of our prostacyclin medications. All right, so we're going to move on to an interactive patient case study. This is Adam. He's a 41-year-old Caucasian male who was diagnosed with pulmonary arterial hypertension 9 months ago. And after 3 months of monotherapy with an ERA, he was switched to dual therapy with an ERA, which in this case was ambrisentan, plus sildenafil, a PDE5 inhibitor. Now he shows worsening symptoms and is intermediate risk on his 4-strata risk assessment tool. Now, what do ERS ESC guidelines say to do now? 1, refer to a PH center. 2, switch to a different ERA. 3, add an IV or subcutaneous prostacyclin. Or D, add an inhaled prostacyclin. All right, 36% said to refer to a PH center, 13% said switch to a different ERA, 27% said IV, add an IV or subcutaneous prostacyclin infusion, and then 24% would add an inhaled prostacyclin. Okay. So this patient has an intermediate high risk status, and triple therapy is what the ERS ESC guidelines recommend at this point. So this patient should have an IV or sub-Q prostacyclin added. Refer to a PH center was not the correct answer because we assume they're already there. Hopefully they got their right heart cath, their initial treatment at the PH center. So that was why that wasn't the correct answer. Switching to a different ERA is unlikely to make any significant difference. The ERAs are all considered about the same. The only way we would ever switch an ERA is sometimes ambrisentan causes more fluid retention than macitentan or bosentan, but switching to a different ERA would not be advancing his therapy. So adding an IV or subcutaneous prostacyclin, that's the correct answer. Adding an inhaled, if he was intermediate low risk, that would have been a good answer, but he's intermediate high risk, so he needs parenteral therapy. Okay, so the patient is asking about possibly adding sotatercept, a drug he's heard about on social media, and what's the correct response that you would give him about this treatment? 1, it's not indicated for PAH. 2, it works only as monotherapy. 3, it's not yet FDA approved. Or 4, it's only approved for group 4 PH. Okay, excellent. 53% of you said not approved yet by the FDA, which is the correct answer. So it's currently under review. Hopefully, mid next year, it will be available to patients. And it is indicated for PAH, so that first one was not a correct answer. It works only as monotherapy. That's not true. It was studied on background combination therapy. And not yet approved by the FDA, correct answer. Only approved for group 4. It's actually not approved for group, or we don't expect it will be approved for group 4. It wasn't studied in group 4 patients. All right. So in summary, pulmonary arterial hypertension is characterized by pulmonary artery remodeling, which eventually leads to an increase in right ventricular size and ultimately right heart failure. PAH, about half of the cases are idiopathic. It does affect all ages, genders, races, most common in women. Nurse practitioners play an important role, are often, like myself, on the front lines taking care of these patients. Multiple treatment options are available now. We have these 3 pathways. If sotatercept gets approved, it's going to be a 4th pathway on its own. We use the drugs in combination, and almost every patient is started on dual oral combination therapy. And then we have multiple drugs on the horizon. Now we have the post-test questions for you. Uh-oh. Did I do something wrong? Okay. Which of the following manifestations would typically be a sign of more advanced PAH? Dyspnea on exertion, heart palpitations, syncope, or hoarseness? Dyspnea on exertion, great. 78% in the pre and 32% in the post. Great, so you guys improved on that. The bottom line is a correct answer, of course, syncope, and 41% said that in the post versus 14 in the pre. So good, you guys learned something. If you see syncope, we're worried. Okay, Henderson, 67-year-old man with scleroderma, presents with recent onset of shortness of breath and unexplained fatigue. Would you suspect PAH? Yes, scleroderma is a strong risk factor for PAH. No, PAH is mostly a disease of younger women. Yes, unexplained fatigue is a strong indicator of PAH. Or no, this patient is experiencing an acute cardiovascular event. Great, 93% got it right. That's great. Yep, scleroderma was the most compelling thing there to consider pulmonary arterial hypertension. So great improvement with that in the post-test. Good job. All right, Emily, she's a 28-year-old female. She presents to the primary care physician with unexplained dyspnea that's been going on for 6 weeks. She was diagnosed with exercise-induced asthma and prescribed an inhaler. Now she presents again to the nurse practitioner complaining of worsening symptoms. Says she can't take her morning jog anymore. She gets too winded and her heart's racing. She complains of an experience at work where she felt anxious, lightheaded, thought she was going to faint. What should the nurse practitioner do? 1, request an echocardiogram. 2, refer Emma Emily to an asthma specialist, request pulmonary function tests, or refer Emily for exercise testing. Outstanding. 84% said what I would do would request an echocardiogram. I tell people in primary care, if somebody's short of breath and they are not responding to their inhaler, which this happens in almost every patient that we see. They first see someone, they get an inhaler. Sometimes they come with a whole bag of inhalers. Inhalers do nothing for PAH because they're opening airways, not blood vessels, right? So I tell primary care folks, think about getting an echo if the inhalers aren't working. You can't figure out, what's going on, get an echo. Okay. According to ERS, ESC guidelines, a newly diagnosed PAH patient with functional class 2, low or intermediate low risk should be treated with which combination strategy? 1, a prostacyclin agonist with a soluble guanylate cyclase stimulator, an ERA and a PDE5, and a prostacyclin agonist. That should have been ERA plus PDE5 plus prostacyclin agonist. That last one is ERA, not ERS. Great. 74% of you got the correct answer, which was an ERA and a PDE5 inhibitor. As you remember, that's a result of the AMBITION study. So great job. All right, sotatercept, a transforming growth factor beta, TGF beta inhibitor, is being studied in clinical trials as what? A, the first one, an initial monotherapy for functional class 1 and 2. 2, a salvage therapy for functional class 3 and 4, a combination treatment with ERA, and add-on therapy to stable treatment. Okay, yeah, very good. The correct answer is at the bottom. Although we didn't have as many answer that correctly as I would have liked. And I think that was my fault. I didn't stress that enough, that the sotatercept in the Pulsar and Stellar studies were, sotatercept was added to dual therapy in stable patients. So that's the correct answer on the bottom. All right, now we're at the Q&A session. Here, and I believe Brett is going to come on and we'll.
Yes, it took me a minute to unmute.
Oh, okay.
Thank you so much, Martha. So much great information. All right, you ready?
I'm ready.
Okay.
Hit
Okay,
me.
obviously a lot of accolades, and thanks so much, and great presentation it was. Thank you so much. Such a good presentation. Couple of questions. As methamphetamines are often used for ADD treatment, we might have meant amphetamines, but it says methamphetamines. Have you seen a correlation to increase in PAH?
And that is a great question, and something that early on, when it became confirmed that methamphetamine is associated with PAH, we thought, oh, the next wave is going to be all these patients that are being treated for attention deficit hyperactivity disorder, and we're going to see all these Ritalin patients and Vyvanse and all these things, and it didn't happen. So we're not sure why those amphetamines have not led to the development of PAH. We still, in our minds, think that it's so reasonable to think that they would. If we get a patient that is diagnosed with PAH and they're on one of those medications, we try to have them work with their doctor to see if there's any non-stimulant, non-amphetamine drug that could be used instead, because there are a couple other options. So we do try to get them off of it if they're on it, but currently there's no established link with those.
Perfect. Okay, good to know. For those with limited resources, uninsured or underinsured, are you empirically treating without a right heart cath? And then it says, hold on, we moved. If so, in what scenarios and symptom management?
The answer to that is still no. Patients have to have a right heart cath. And I get, if you don't have insurance, that can be difficult to do. The one way that we address this in some situations is many of our clinical trials will pay for the right heart cath. So we try to get patients enrolled, consented for a clinical trial, and then get their heart cath that way. In Dallas, we have Parkland, which is where our indigent patients go, or unfunded patients, and we have people at Parkland that can do the right heart cath for us. Now, of course, this is going to vary all over the place, but I would still say never make the diagnosis without a right heart cath, because you have to have that pulmonary artery wedge pressure to distinguish between group 1 and 2, and it's the only way to get it. And if you try to just do this on echo, they've studied this in 2 different studies, you're going to be wrong 50% of the time, and there will be potential to harm the patient, because if they're really group 2 and you give them group 1 drugs, you can harm them. So that's why we never ever do it based on anything but a right heart cath.
So more than anything, know your resources.
Yes. And know your closest pulmonary hypertension center, send them there, because like I said, we've got clinical trials and different ways sometimes to work around things.
Perfect. What percentage of these patients have sleep apnea?
It's a high percent, and I don't know the percentage. I read this recently though, and it seemed like it was really high, like 40 or 50%, but don't quote me on that because this is out of my memory. I don't know for sure, but it's a high percentage. I do know that for sure. Years ago, we thought that sleep apnea alone could cause pulmonary hypertension, and maybe it can, but if it does, it's very mild, and it's when the sleep apnea is not controlled and they're hypoxic at night, so it causes like a little group 3 pulmonary hypertension. So years ago, we would tell people, wear your CPAP religiously, 3 months, then we'll check your echo or your cath again and see if it's gotten better. I don't think I ever saw anybody normalize just treating their sleep apnea, but if they have sleep apnea, which many of them do, we highly encourage that they're compliant with their CPAP to prevent nocturnal hypoxia, which can worsen pulmonary hypertension. And because of that, because there's such a high percent of patients with sleep apnea, we get a screening overnight oximetry on all our patients to check. And if they're hypoxic during the night, then we send them for a full sleep study at sleep clinic.
Awesome.
And I don't know why. I don't know why it's such a high percent, except that many of our patients are obese because they're so sedentary from being short of breath, they're not able to exercise. So maybe this high obesity level is why we have so many sleep apnea patients. But
well, you're a co-investigator on other research. Maybe you need to do some research. I'll give you something else to do. No, that's really good information. I have a couple people asking about a 10-minute break. I think we have about 5 more minutes of questions, and then I don't think it would be wrong because we do not start with our next speaker until right at 12 o'clock Eastern. So I think we can do a 10-minute break unless anyone has any difference on that of our leaders of this CE event. So I'll defer, but I think we're okay to do that. So just a couple more questions.
Okay.
Oh, and you mentioned about pulmonary centers. So are those in pretty much all states?
Yes.
Obviously they're probably going to be in bigger academic centers, but are they usually throughout the whole US?
Yes. And the way to find your nearest pulmonary hypertension center is to go to the Pulmonary Hypertension Association website. It's phassociation.org. And you can go on there and it shows the map of the United States and where all the centers are. And then you click on it and you can get the information. the centers are accredited through the Pulmonary Hypertension Association, and there's comprehensive care centers. That's what we are, and that means we provide all therapies, including the parenterals, and we do research and some other things. And then there's regional care centers, or RCAs, which don't offer the full plethora of things that you could get at a comprehensive care center, but those people are very educated and know what they're doing. And RCAs are fine. If the closest place is an RCA, they usually are working closely with their closest comprehensive care center. So either one is fine, an RCA or a comprehensive care center.
And somebody else kind of made a statement and said, so we know it's kind of a protracted period to diagnose. And then oftentimes life expectancy can be short, like 3 years. So they just kind of put that out there. In my mind, as a palliative provider, I see so many of these patients. So I think early palliative referral is really, really helpful. I mean, I'll defer to you, but really early palliative referral so that we can help manage their symptoms and kind of help them make the most out of, that 3 years or however, as we get better and better with treating it.
I agree completely. And also our palliative care program helps patients with end of life planning, getting an advance directive and all of those things that we're not very good at actually, but so we appreciate our palliative care colleagues. When we have somebody that's on prostacyclin infusion, so IV or subcutaneous infusion, that's progressing usually toward the end of their life, we want to make sure all of those patients have been referred for sure. But to your point, even earlier than that is better.
Perfect. And then finally, has COVID-19 had any effect on type 2 PAH rates?
Not that I've heard. It has. There are some reports. I don't know how well studied, but there's definitely anecdotal reports of centers seeing more CTEPH patients. You may remember that COVID is a hypercoagulable state, and a lot of people have PEs when they've got COVID and they're really sick and it's running clots and they anticoagulate patients. And so because there's more of that, it leads to perhaps we're seeing more CTEPH patients, but I have not heard more group 2 patients from it.
Good to know. Well, thank you so much, Martha, for being here.
Thank you so much for having me.
Thank you. So for all our participants, let's take a 10-minute break and then we'll come back with Leanne Simpson, and she's going to be talking about integrating multi-cancer early detection testing. So I'm really excited about that. So 10-minute break.